My name is Mike Kolena, and I'm the Chief Executive Officer of Windrose Health Network. And the purpose of this presentation is to give you, the viewer, a quick overview on what a federally qualified health center is. And so I thought we'd try to answer the who, what, when, where, why, how, and how much of FQHCs. To start with, who are FQHCs? Well, they're actually a reflection of an interesting business model, what they call a public-private partnership. And nationally, what occurs is that local businesses, local companies, 401, 501c3 companies apply for becoming an FQHC. The funding comes in part from the federal government, in part from the state, sometimes, depending upon the state. And ideally, there's some support from the local community. And that's one of the beauties of this model, is that not only is there something from government, but also local communities contributing. And most importantly, the majority of the funding that occurs, the revenues that are created through an FQHC are created through service. And put simply, if FQHCs don't serve patients and get paid for it, then they go out of business. And so in that regard, this business model is truly consistent with what we've been doing in this country for several hundred years around business and industry. See, because of that, and something to keep in mind in weighing this particular politically driven service and opportunity, is the fact that FQHCs are employers. Nationally, FQHCs employ more than 190,000 people. In the state of Indiana, it's more than 1,300 people. So if that's the who, let's talk about the what of an FQHC. What happens around how a company becomes an FQHC? Companies cannot just decide one day to become an FQHC. They are awarded that designation by being the winner of a competitive grant process. How that occurs is that the Health and Human Services has a branch called Health Services and Resource Administration. HRSA is the nickname for it. HRSA is the organization that has run the FQHC model since 1965. They go to certain parts of the country and inform the community and throughout the state, say we're going to award an FQHC for services in a particular area. Most recently, one was awarded for the state of Indiana. 2 organizations got awards. I've seen them more specifically targeted for parts of the country, say could be Austin, Texas, or could be Memphis or someplace like that. The what of it also involves some other unique characteristics. In addition to being a 501c3, FQHCs, although they work with hospitals, cannot be part of hospital systems. They have to be standalone companies. And FQHCs have a very unique qualification. They're run by a board of directors, and the board of directors must be comprised of at least 51% of the people on the board are consumers of the services of the FQHC. This gives not only a local flavor to the care that's delivered, but also gives the board and the chief executive officer direct feedback about how well services are being provided and how well people's needs are being met. Another part of the what is, this whole model is premised on the idea that it's affordable care, it's not free care. This has been a mainstay of this model since it began. Once again, the idea was that the community and the patients are contributing to improving the health care of the community as well as the individual. This is done in part through a sliding fee scale. The sliding fee scale allows the FQHC to identify people eligible for it. These numbers are based on the federal poverty guidelines, which are published every year in February by Health and Human Services. Ultimately, in our case with Windrose, someone can go up to 200% poverty, which in 2017 is about $11,800 for an individual and about $24,500 for a family of 4. Ultimately, if you're at 100% poverty and designated in that category, we will charge you a nominal fee for the services you receive. Typically, across the state of Indiana, that's somewhere between $15 and $25 to see a board-certified medical professional in most cases. The win of this has been, this program has been going on since 1965. As I said earlier, it's gotten bipartisan support from both sides of the aisle in Congress. It has grown in leaps and bounds in some instances. Other cases, it's just been very static. All right, now that in 2017 is fairly static because of the debate in Congress around healthcare. So where are the, what locations? Well, the premise of this model is simply this. Let's put healthcare, let's make affordable healthcare available in the neediest communities. That was the underlying intent all along. That started out in 1965 as part of Lyndon Johnson's War on Poverty. And the first two health centers were one was placed in the Mississippi Delta and one was placed in a public housing project in Boston. The why of this, quite simply, it's a very simple mission, 100% access, 0% disparities. We try to serve everybody. We try to find ways to transcend normal barriers to people getting care, such as geography and finances. The how of this, the goal of an FQHC is to become a medical home for the patient and or the patient's family. By a medical home, we mean that our role is to provide comprehensive outpatient, primary, and preventive care. It's based on the family medicine model in which you serve the patients, all the needs of the patient, and if they get to certain issues, but get to a certain level of need, then you bring in a specialist or you get the patient to a specialist. I know FQHCs that not only provide medical care, but also behavioral health and dental and even vision care. Lastly, the idea is that the FQHC helps its patients access other care throughout the community and even the state. And in this instance, the example I would give you is in this part of the country, if a child has some particular needs, they're going to probably be referred to Riley Hospital in Indianapolis. It's a regionally known quantity. In fact, it's got a national reputation, and it specializes in dealing with pediatrics when there are unusual needs or circumstances. The FQHC's job not only helps an individual access that part of care, but also something as simple as how do I get my medications. If I can't afford them, if the patient struggles to afford them, the FQHC will try to find ways to help the patient connect with. Most pharmaceuticals have some type of indigent need program. The FQHC helps the patient obtain that. And the last thing is to just, as I said earlier, they are geared to helping patients get either outpatient specialty care or hospitalization if possible. In that way, this is a very comprehensive process. So to sum it up, that's the who, what, when, where, why, how, and now the how much. FQHC has been around for, now it's, let's see, 52 years. After starting with 2 health centers right now in the United States, there are more than 1,400 companies that are FQHCs. Those companies have more than 9,800 service sites. In 2015, they served 24 million Americans. That's 1 out of 13 people in our population. And they provided over 75 million outpatient visits. That's million with an M. In Indiana, there's been a parallel process of growth. Indiana in 1997 had 4 FQHCs and somewhere between 30 and 40 community health centers that were supported by the state. 44 service sites, they served about 67,000 patients and they had about 304,000 outpatient visits. Today, or I should say in 2015, there are 26 FQHCs and 22 community health centers. Some of those previous community health centers became FQHCs. They have over 160 health center sites or service sites, in addition to which they have mobile vans for not only dental care but outpatient primary care, and there are at least 35 school-based clinics across the state. In 2015, they served 445,000 patients, providing basically 1 out of 15 Hoosiers with care, and they delivered over 1.5 million outpatient visits. I hope that gives you a little background on what we are, what FQHCs are, and I hope this proves to give you information you use. Thank you.